like to tell you about a patient. Let's call her Alina. Alina had some health issues and she sought out the help of a genetic counselor. During their session, they dove into her family history and explored different options for testing. As the appointment came to an end, the genetic counselor asked, "Would you like to move further with testing?" Alina replied, "I'd like to speak with my husband first." The genetic counselor smiled and nodded, "Of course, but remember, ultimately it is your decision." To the genetic counselor, by reminding Alina that this is her choice, she felt she was empowering her patient. But to Alina, being asked to make this choice alone felt isolating. Alina never came back for her follow-up appointment. Unfortunately, these cases are not uncommon in a genetic counseling setting. Genetic counseling is a healthcare service that allows patients to understand how their genes affect their well-being, exploring options for testing, and making future plans for health. Due to the sensitive nature of genetics, decisions for patients can be deeply personal, often shaped by their family and cultural values. As our medicine advances, we must consider how it affects our populations on a moral and social level. Western cultures have placed an emphasis on autonomy, stemming from our value in the individual over the collective. This idea arose during the Enlightenment from the philosophy of personal liberty. This idea was later reinforced throughout history through cases of paternalistic medicine, where physicians would make choices on behalf of their patients without their consent. These choices have shaped Western cultures and medical decision-making for years. But this does not necessarily hold true for other cultures. Traditionally, in the US, genetic counseling employs a non-directive approach. In your training, you are taught to present all the necessary information to your patient without bias, while avoiding directing them towards any particular outcome. This is especially seen in the prenatal setting. When working with parents, you never want to be coercive or suggestive in your language. The goal is to make sure that your patient can make a well-informed decision that aligns with their personal preferences. In many ways, this models a protection of patient rights. But for patients that come from family-centered or collectivist cultures, this model can feel uncomfortable or even isolating. In many parts of the world, medical decision-making is not only shaped by personal preferences, but by deeply rooted cultural values. For example, the idea of filial piety places an emphasis on a moral obligation to parents and elders, often placing their opinion over others. Patients from these cultures may wish to have their parents present at appointments and may wish for them to play an active role in discussions. This does not show a lack of understanding or a lack of autonomy, but rather a different idea of where responsibility lies. A similar Confucian philosophy called ritual governance holds the idea that people should fulfill a social role and follow a social hierarchy. Under this belief, patients may take a more passive role in their care, often deferring to physicians for their opinion. This can be seen in a lot of East Asian countries such as China and Korea, where Confucianism played a deep role in shaping the culture. Patients from these backgrounds may place their medical practitioners in a place of authority and may expect them to provide more direct guidance. This can put pressure on genetic counselors who tend to shy away from such straightforward advisement. If we look at societies across the Middle East and West Asia, they may employ a more patriarchal family structure, where the male head of the family is often the one who makes decisions for family well-being. In these households, the husband or the senior male relative will play a central role in the decision-making, often including medical decision-making. To these families, the system is not seen as restrictive. It is rather reflective of long-standing traditions that have provided stability and protection for many years. However, in Western medical ethics, we may view this as limiting, especially for female members of the family. This highlights a complexity that healthcare providers may encounter when ethical frameworks intersect with cultural values. Using a strictly autonomy-centered model assumes that people prefer to make decisions alone with neutrality from their provider. But for patients from family-centered cultures, they may view medical decision-making as a shared responsibility. An overemphasis on autonomy risks creating health inequities between the genetic counselor and their patient. Patients may feel mistrust or discomfort, and genetic counselors may feel tension between the training that they received and the personal preferences of their patient. We risk creating these gaps if we continue to prioritize a Western way of thinking. But we can begin to address these issues by reframing the way we approach our appointments in genetic counseling. Instead of creating a polarizing stance between individual and shared decision-making, we can employ a flexible decision-making model that addresses this wide spectrum of cultural values. We can begin to ask questions such as, who would you like present at this appointment? Or how are decisions typically made within your family? We should strive to teach cultural humility within our classrooms and address the limitations of non-directiveness. And this can be applied broadly across medical specialties, across professions, and across the globe. It speaks to a broader issue within modern healthcare today. How do we offer ethical care in a world that is culturally diverse? Western philosophies have protected the rights of patients for years, but it is not necessarily the only framework through which people understand their health. Cultural competency begins when we stop assuming that autonomy looks the same for everyone. Thank you.